Welcome to this, the first in the series of trauma and orthopaedic lectures for undergraduates based on the medical licensing assessment. As I'm sure you're aware, the MLA starts in the academic year 2024-25 and has two parts: the applied knowledge test and a clinical professional skills assessment. The MLA has a guideline for both presentations and conditions, and this is a summary of those conditions and presentations relating to musculoskeletal pathology. The ones highlighted in yellow are really related to rheumatology, and we're not going to be covering those in these lectures. We're going to focus more on the ones related purely to trauma and orthopaedics. So this first lecture focuses on the orthopaedic emergencies: compartment syndrome, cauda equina syndrome, and septic arthritis. We're focusing on these partly because they appear in the MLA and partly because these are things that you will see in your practice as a doctor, not only if you do orthopaedics or accident and emergency, but they will appear on the wards, they may appear and in your GP practice. So you need to be aware of these, how to diagnose them, and the elements of how to treat them. So these appear, as you can see, in a number of places, both in the presentations and the conditions, and an extent a little bit more than what we've covered here. So if we focus on the first one, compartment syndrome, there is a rather long and wordy definition, but essentially it's a raise in the pressure in a compartment that reaches a threshold where you get microvascular compromise, which then results in increased pressure and myoneuronal function impairment, which is muscle and nerve impairment, and necrosis of the soft tissues, mainly the muscles. So if you look at the pathophysiology, the vast majority are related to trauma, and the majority of trauma is related to fractures, with the consequent muscle and soft tissue injury, with hematoma and edema as a consequence. You also see it traumatically with crush injuries, even with simple contusions if you've got a large enough hematoma there, and fortunately in the UK, rarely with gunshot wounds. It can also be, as a consequence of trauma, iatrogenic. If you put a tight cast on or a tight bandage on, you can get iatrogenic compartment syndrome, where you don't allow that compartment to swell as it normally would. The other iatrogenic cause, of course, is extravasation of IV infusions. If you're drip tissues and you keep putting the fluids in, you can make a compartment swell. You need to be aware of a couple of other ones. Circumferential burns will stop a compartment from expanding, in addition to the edema that you get. So you can get compartment syndrome as a consequence of burns and of arterial injury, particularly as a reperfusion injury. And this goes along with post-ischemic swelling. And be aware of patients who have either got bleeding disorders or who are anticoagulated, as they may get more swelling than you would anticipate from a simple injury. So if we look at the pathoanatomy of compartment syndrome, you get this local trauma and soft tissue damage. That results in bleeding and edema, which raises the pressure in the compartment. This leads to vascular occlusion, predominantly initially the capillaries. Venous compression comes later when the pressure's gone even higher, and ultimately you can get arterial pressure, but this is where you're really moving into compartment syndrome, leading to an ischemic limb, and these are quite rare. So the first thing you get is muscle ischemia, because the muscles are most metabolically active, and then neural ischemia. And because you've got the ischemia, you get this spiral of events. So just take a moment to think about the classical symptoms of compartment syndrome. What are you expecting to see? The answer is pain. Pain out of proportion to the injury, and then you may see swelling and tightness. The difficulty for most of us is we don't know what that pain actually means. Most of us have not had a broken bone, so we don't know how painful it is. What we usually see is that the patient complains of pain from their fracture, they get analgesia. This doesn't seem to control the pain, or it doesn't control it for long enough. They then require more analgesia and more analgesia. And you can see the inherent problem here with the shift pattern, that this patient could be seen by 4 or 5 doctors over the course of a day, each one not being aware of quite how much pain relief they've had before. So just be aware, if you're on the wards at night and a patient is requiring more and more analgesia, that this might be a brewing compartment syndrome. However, there are a group of patients where you don't necessarily get this classic presentation, so just take a moment to think about who this might be. So, here you go. If you've had an anaesthetic block, either as a result of surgery or an accident and emergency, you will not feel pain. This could be in the upper limb, brachial plexus block, in the lower limb, a femoral block, sciatic block, something like that, which is done with good intentions but prevents the patient from telling us that they're developing a compartment syndrome. Equally, particularly patients on ITU will not tell us that they're getting swelling and pain in their leg because they're intubated. And patients who've got spinal cord injuries may well have other fractures, which they firstly won't tell us about, and secondly, they won't be able to tell us about compartment syndrome. There is another group of patients who may or may not be able to really tell you what's going on. So children are very good at telling you about pain, but won't necessarily be able to tell you about the type of pain, where it is it getting worse. Equally, patients with a low GCS, so this could be through head injury or through intoxication, may not tell you very much about their pain, and to a lesser extent, patients with neuropathy may not be able to tell you about increasing pain. So when you examine them, the classic findings is pain with passive stretch. Now obviously, moving damaged muscles over a broken bone is going to hurt, but if you do it gently, it shouldn't be too bad. If you do it with somebody with compartment syndrome, you get increasing pain. And this is the most sensitive finding. Swelling is very non-specific, and if you look for it, there may be altered sensation. Now in the upper limb, that is classically the median nerve distribution, but in the lower limb, it's really you just get a little numb patch between the big toe and the second toe, which is patients will often not really complain about. You'll have to go looking for it. Paralysis is difficult because it's often in the presence of a fracture, and peripheral pulses is really an ischemic limb, which is much, much later. So there isn't a good imaging modality for compartment syndrome. You can take x-rays to rule out a fracture, but you've probably already done this. There is a thing called compartment pressure monitoring, where you put a needle into the compartment and you've either got a machine that will tell you the compartment pressure, or you can hook it up to an arterial pressure monitoring machine in the operating room. This will tell you what the pressure in the compartment is, and there's a formula which basically states that if the difference between your compartment pressure and your diastolic pressure is less than 30 millimeters of mercury, you've got compartment syndrome. Unfortunately, this is a really, really unreliable finding. So don't use this as your diagnostic tool. It can be helpful, and in some places it's done in ITU to monitor, to see what's happening, but it's not a standard test that's done, although people will often ask what the compartment pressure is. And certainly if it's significantly less than that 30 millimeters, then quite probably you've got compartment syndrome. Now, there are guidelines written by the orthopaedic surgeons and the plastic surgeons for how you should diagnose and manage compartment syndrome. You need to be aware that they exist, but you are not expected to know what these are. But if you want to read through them, you certainly can. So your treatment, like anything, is non-operative and operative. So non-operative doesn't mean ignore the patient, it means observe. And these are the patients where your gut feeling is that they don't have a compartment syndrome, or this diastolic differential is more than 30 degrees. And you may be thinking this isn't really a compartment syndrome. It means you've got to watch it until you've proved it isn't. Obviously, if they've got a cast on or a dressing, you bivalve it. You split the cast or the dressing right down to skin to give the compartment a chance to swell, and then you keep watching. Now, you may in your reading come across hyperbaric oxygen therapy. This has been described, but in reality, most of us don't have access to a hyperbaric oxygen chamber, and therefore it's not really going to happen, but it is in some textbooks, so you just need to be vaguely aware of it. The treatment, very simply, is an urgent fasciotomy. So this is one of the things where you're the junior doctor, you pass it up the chain as promptly as you can, and the consultant may well come in the middle of the night to do this. And the standard operation for the lower limb, which is the most common, is a fasciotomy of the lateral and the medial sides, where you open up all of the compartments. You don't close the wound primarily, you just dress it, and the plastic surgeons will then come back and typically put a split skin graft on, and then close the wound up months later properly, removing the split skin graft. If we move on now to cauda equina syndrome, the basic definition is compression of the nerve roots in the sac of the lumbar spine. So it's a nerve roots in the lumbar spine condition. So this is covered in the MLA conditions, as you can see, with spinal cord injuries, radiculopathies, and to a degree pathological fracture. So a little bit of reminder of the anatomy, that the spinal cord proper ends in the conus medullaris at about the T12L1 level. After that, all the nerve roots come down and exit at L2, L3, all the way down to S4. And this is the cauda equina, or the horse's tail. And there's also a little thing, the filum terminale, which is a little fibrous extension. You don't need to worry about that. And you need to remember that the bladder has got a parasympathetic and a sympathetic innervation, and the external sphincter is under voluntary control. But all of these are related to these nerves. So the biology of this is that if you press on a nerve, it decreases the nutrient artery blood supply, so you get decreased blood flow and CSF diffusion. You then get intraneural edema, which reduces the perfusion pressure, and you get nerve root ischemia. So fundamentally, this is an ischemic problem of the nerve root. There are a whole load of causes, which is anything which reduces that space. So disc herniation, particularly if it's a central disc and it's large enough. If it's peripheral, it will take out some of the nerves. So you may get sciatica. If it's central, it'll take out the ones in the middle. You can get it with a hematoma, which could be a spontaneous one in an anticoagulated patient or a patient with a bleeding disorder, or very importantly, following an epidural. So again, just have the antennae up. If somebody's had an epidural and they start to complain of odd neurological symptoms, could this be a cauda equina? You can get it with tumours. So these are the primary tumours that you get in the spinal cord, but you can also get it, if you look at the trauma list, you can get it in there with pathological fractures and propulsion of fragments. And again, with the trauma, you can get anything which makes that vertebra collapse and retropulsing fragments. You get it with dislocations, and also with abscesses, and to a lesser extent with developmental problems. But the majority are really disc herniations or trauma. Now the presentation, very importantly, is the bit in bold. No single symptom or combination of symptoms has good diagnostic accuracy. But the symptoms include leg pain and back pain, so a sciatica picture, and it may be one-sided sciatica with cauda equina, or it may be bilateral sciatica, and certainly bilateral sciatica, you've got to think that something's happening in the middle. There may be problems urinating, either initiating it or an impaired sensation of urine flow. And very importantly, if they have no bladder sensation, they won't feel the bladder filling, and then there is an overflowing continence without sensation. And that is often what drives the patients to accident and emergency, is repeated episodes of effectively an overflowing continence. They may get altered perineal sensation, but again, this is not a common thing to present with, as is sexual dysfunction or a loss of sensation of rectal fullness. Again, they're not common presenting features, although they may admit to it if asked. But certainly progressive neurological deficit in both legs comes back to that bilateral sciatica problem. On examination, there may be spinal tenderness if it's a spinal problem. And they may have an enlarged bladder, but this is often hard to pick up. Your neurological examination is going to be from L1 all the way down to S4, and it's very important to document everything that you find, positive and negative, because this often is an evolving problem. You must check perianal sensation, and there's an S234 target around the anus, so check that both sides. And you have to do a rectal examination for both anal sensation and for tone, and this is the squeeze test. And you can either ask the patient to squeeze or to cough to see if there is actually contraction of the sphincter. And again, document your findings, whatever you find, because things can change either in hours or days. Investigations, very simply, you take an x-ray because you may see vertebral collapse, fractures, or a spondylolisthesis, which is an indicator of a problem. You can do a bladder scan, but very importantly, this is not diagnostic. So 60% of patients who've got cauda equina syndrome will have a normal post-voiding residual volume, or a volume less than 200 mils. However, if you've got a volume of more than 200 mils in a patient with suspected cauda equina syndrome, then it is 20 times more likely. So big bladder, strongly suggestive, small bladder doesn't help you. And ultimately, you're going to get an MRI. And the management, again, conservative or operative. Conservative, if you really, your clinical picture and examination don't line up for cauda equina syndrome, then you may want to observe the patient, and you've got a negative MRI, then watching the patient and reviewing them is probably a very sensible thing to do. If you've got a clinical picture and an MRI suggestive of cauda equina syndrome, then you need to speak to either your spinal orthopaedic surgeon or the neurosurgeon, depending on your facility, and get this patient seen with a view to urgent decompression. Again, this is not one you want to sit on, because as we said right back at the beginning, this is ischemia of the nerve roots, and this is then permanent damage, and you can lead to permanent incontinence if you don't pick these things up promptly. So finally, we'll look at septic arthritis. So very simply, this is inflammation of the joint secondary to an infectious etiology. And this covers a whole load of things, because as we're going to see later on, your differentials relate to all of these forms of arthritis. So the anatomy, the pathoanatomy, is these are a bacterial infection. So this may come from a bacteremia, bloodborne, or it may be direct inoculation, which can be traumatic, kneel on something sharp, could be post-surgical, or it could be after an injection or aspiration. Remember, these are done very commonly in GP surgeries and outpatients departments. Or it could be from an adjacent osteomyelitis, although these are less common. The majority are a Staph aureus, but do think about these other organisms. Sexually active patients, gonorrhea, it's uncommon, but it is there. In immunosuppressed patients or patients with populations of high TB prevalence, think about TB. Again, it gives you a slightly different presentation because they don't tend to be very hot, but do think about them. And then think about MRSA as a hospital-acquired form. So anatomically, half of them are in the knee, and then a smaller number are in the hip, and these are more commonly in children, and then more rarely you'll see it in the shoulder, the elbow, the ankle, or the sternoclavicular joint, but these are pretty uncommon. There are some risk factors, and you can pretty well guess what these are. These are being older, having those medical conditions that predispose you to infections, so diabetes or rheumatoid, a history of a damaged joint, so crystal arthropathy, arthritis, give you a surface which is more amenable to the bacteria. A history of endocarditis leads you towards maybe a bacteremia. Equally, an IV drug abuser may lead you to a bacteremia. and that history of any recent joint surgery, so arthroscopy, joint replacement, or an aspiration or injection. All of those obviously increase your risk of getting a septic arthritis. So the pathology of this is that you get bacteria in there and they start to grow. So you then get an immune response to the bacteria. So you get macrophages and phagocytic and bactericidal produce, which unfortunately is damaging to the cartilage in there. There is an acute inflammatory response with cytokines and histamine, which again are not good for cartilage. And the bacteria release toxins and various other products which are quite acidic, and that again damages the cartilage. So you've got all of these happening and swelling, so you get an increased intra-articular pressure which compromises the blood supply, as well as direct damage to the cartilage. So they present with a hot, swollen, tender joint with a restriction in active and passive movement. The majority are in a single joint. However, bear in mind that 3/4 will have joint pain. Again, about 3/4 will have joint swelling. About half will have a temperature, and even fewer will have sweats or rigors. So actually, it can be quite difficult to work out that this is septic rather than one of the other differential diagnoses. When you examine them, you may see erythema. You'll probably see swelling. The joint may well be warm. There may well be generalized pain and tenderness, and there will be an effusion. And there will be a reduced active and passive range of motion, with quite probably an inability to walk due to pain. However, this isn't always the picture. They're often not particularly red. And if the patient isn't Caucasian, that can be very difficult to pick up anyway. So again, this presentation looks very much like some of the other presentations that you might expect in the knee, like arthritis. So your investigation is very simply, you're going to do the bloods. You need a full blood count, particularly for the white count, and you need an ESR CRP. And very importantly, if you are thinking there might be a septic joint, get the blood cultures off early. An X-ray can be helpful. Certainly if you've got an osteomyelitis going on, it'll pick that up. It'll also tell you if you've got an arthritic joint. So assume if you've got these features, it is septic until you've proved it's not. You can use the Cocker criteria. So this walk few. So can they weight bear? Do they have a temperature? Do they have a high ESR or CRP? And do they have a high white count? Now this can be useful because if you've got 3 or 4 of these features, then you are highly likely to have septic arthritis. If you only have 1 or 2, it's pretty unlikely. So this can be useful. It starts to add to the general picture of the diagnosis. Really, to make the diagnosis, you need to aspirate the joint, and you do this before antibiotics are given. Now, one important thing here, if the patient has a knee replacement or a shoulder replacement, whatever it may be, you need to do this in the operating room where it is clean, because the last thing you want to do is to put your needle in the emergency room and introduce infection into a prosthetic joint, because that's a disaster. And you're going to send this fluid off for an urgent gram stain white count and microscopy, as well as culture. And you can see from the table below that obviously if you've got a straw-coloured fluid with very few white cells in it, it's probably going to be normal. Or on the other end, if you've got an opaque, cloudy, pussy-looking thing full of white cells, it's probably infected. And then your gram stain obviously will help you there. We've alluded to the differential diagnosis, and you could probably work this out. A reactive arthritis, very common in children. Think about gout, pseudogout, all the arthritides, because they will all give you exactly the same clinical picture. And one would hope that you'd pick up on trauma and that sort of thing as part of your history taking. And the reason that we get excited about this, and it is an orthopaedic emergency, is because very rapidly you destroy the joint. which then means you've got an arthritic joint, which then means that you may need to be thinking about a joint replacement. And unfortunately, if you've got a background of septic arthritis, you're then jeopardizing any primary joint replacement that you put in to getting that infected. So we're very, very worried about these. Untreated, they can track through, become an osteomyelitis, which is obviously an even bigger problem, and the patient becomes septic. Not always, but certainly if they've got any of those immunocompromising things, then they can become quite septic, although fortunately it's relatively rare to die as a consequence of this. So the treatment is pretty simple. If they are septic, then you start the septic 6 and treat them for sepsis. Ideally, if you can get any culture off beforehand, that's very beneficial. If it's a native joint, then you need to reduce the bacterial load quickly. So that's taking them to theatre and washing the joint out. And this is typically arthroscopic. It may take several attempts, so they often go back to theatre 2 or 3 times to keep irrigating and shaving any rubbish out of the joint to reduce the bacterial load and protect the joint. If it's in a prosthetic joint, you still wash it out primarily, but there is a very real chance of having to remove all of the prosthesis, clean everything up, and then stage going back and putting in a new one. So this is a big deal in infection in a prosthetic joint. So that brings us to the end of this lecture, and we've gone through these 3 common orthopaedic emergencies: compartment syndrome, cauda equina syndrome, and septic arthritis. So hopefully you've now got enough information to guide you through the MLA and also to help you think about these diagnoses and make them, if you need to, on the wards, in the emergency room, in whatever your practice is in the future. So please look out for the other talks, which will cover all of the rest of trauma and orthopaedics, joint by joint, as well as covering fractures.